You're listening to Health Professional Radio with Wayne Buckler. This is the Health Academy, our regular chat with academics who are working in medicine and researchers and clinicians, both who are working in particular areas. And today, our guest is Mark Hancock. Mark is with Macquarie University Hospital and is a specialist in musculoskeletal physiotherapy. And I think, Mark, a particular interest in the lower back.
Yes, that's correct, Wayne.
Now, Mark, thanks for your time in talking to us on Health Professional Radio. We like to get our ears into the academic sphere from time to time to hear what's going on. Tell us about your research and what's been happening.
Sure. Wayne, most of my research covers pretty much all aspects of back pain, so I'm involved in diagnosis, prognosis, and treatment studies. But I guess I have a particular interest in a better understanding of the causes of back pain and how we identify what we might call subgroups of patients who respond best to particular interventions. So to give you a little bit of background, for the last 15 or 20 years, pretty much all guidelines around the world have recommended that back pain is managed with a diagnostic triage. So this involves identifying patients who have serious causes for their back pain, so things such as fracture or cancer, and then also identifying patients who have nerve root involvement, what we might commonly call sciatica. And then it's recommended that the rest of the patients, which is pretty much 85 to 90%, are considered to have non-specific or simple back pain. And I guess it's been argued that it's neither possible or necessarily important to identify the cause of these patients' pain, and that we can treat them without that. But we've been following this approach for quite a long time now. And what we've found with a lot of big trials that we've run is that most treatments have a small effect on these patients, but we're really not getting the good outcomes that we'd like to.
It does seem, Mark, from a layman's perspective, that back pain is very common, but the treatments are very different.
Exactly. There's just a huge range of treatments that are out there. And at the moment, there's not a really good reason. I guess I'd argue that many patients are getting the particular treatment that they get. So what we've really become more and more interested in is trying to work out which patients require which type of treatment. And if we do, then hopefully the outcomes will be much better. So when you talk to clinicians or patients, they'll often say, look, a certain person's done very well with one type of treatment, but other patients do really well with a different type of treatment. And that would seem pretty obvious. But it's actually not the way most of the big trials, for example, are done. So in the big trials, you take this group of non-specific back pain patients and they will all get manual therapy or manipulation, or they'll all get a certain medication. And as we said, we're getting disappointing results with that. So broadly speaking, my interest is in trying to, better target the right treatments to the right patient.
Now, I see on your bio that you've published over 70 journal articles, and including some of the big names, Lancet, BMJ, Archives of Internal Medicine. So I'm assuming that evidence-based medicine is very much in your focus. How should these trials be conducted if what we're doing is not working now?
Sure. Look, what we're trying to do are, I guess, develop trials that within the trial design, try to answer this question of whether patients will do better with specific types of treatments. And there are some of those trials that have started to come out more recently. So, as an example, there's a trial that was called the Start Back trial that was published in Lancet a couple of years ago from Jonathan Hill and some colleagues at Macquarie University. And so they've looked at a targeted or stratified care approach where they use a simple tool to identify initially patients that are likely to recover well without much intervention, or patients who have a poorer prognosis. And then based on this information, they've then targeted both the type of treatment but also the amount of treatment to those different individuals. And what they found in their trial is that by doing this, they did produce better outcomes, but interestingly, in the patients who had a good prognosis, the outcomes were just as good if they gave them very little treatment. So basically, they're saving money in that group of patients, and then I guess using that money to provide more and better treatment for the patients, who are more likely to go on to develop chronic pain.
So is it your view, Mark, that there is a lot of over-treatment of simple back pain?
Absolutely. I think we've got really strong evidence. We've done quite a few big prognosis studies looking at the course of back pain. And we know that the vast majority of people who have simple pain and haven't had it for very long, just a week or two, a lot of those patients will recover very well with minimal treatment. And there's really strong evidence for that now. So again, that's one of the challenges, is to clearly identify those people who need simple treatments, just good advice, good reassurance, possibly simple medicines, and then, really just monitoring those people over the first couple of weeks. But some of our big studies would show that probably 80 to 90% of those people will recover within 2 to 3 months if they're pretty much left alone.
Is there room to suspect that some of this back pain is kind of chronic lifestyle issues that really ought to be prevented rather than treated?
Yeah, it's a very interesting question. We've become more and more interested in prevention at the moment, because whilst I told you that many people with back pain recover well, we also know that a huge proportion of those patients will have recurrences. So some of our studies would say about 50% of patients will have a recurrence of their pain within a year. So prevention, is really an area we need to look at more. It's actually an area that there's surprisingly little research in back pain. There would be 10 times as many trials on treatment as there are on prevention, probably far more. With regards to lifestyle factors, again, we don't know enough about it, and I think that's the challenge. We need to go back and better understand, which variables and lifestyle factors are critical for back pain, and then as we better understand those, then we'll be able to target the treatments more effectively.
And I guess funding is always an issue here. It's always easier, I think, in Australia particularly, to get funding for ambulances than it is to get funding for road traffic signs. We seem as a culture to be much more interested in the end of the process rather than the beginning. Is funding difficult to get for these studies which are about prevention?
Absolutely. That's very much been our experience. We've had a prevention trial we've been trying to get funded for a while now. We've got small amounts of funding, but really not the funding to do the big trial we'd like to. And that's exactly right. It seems to be easier to get funding, for patients with pain rather than to prevent it. But really, long term, I think prevention is probably going to be, arguably more important in back pain. And generally speaking, back pain and musculoskeletal conditions, whilst, they're responsible for a huge amount of the burden of health conditions, they don't tend to get the funding, some of the other more life-threatening conditions.
Yeah, I can see how a funding body would be influenced that way. Mark, do you think there's an increasing prevalence of back pain? Is it something that's been growing? In my head, I think, generally work's become less manual and workplace health and safety's become more conscious of safe processes. Is the incidence increasing or decreasing?
I think the best evidence we have is that it's probably fairly stable, but if anything, increasing rather than decreasing. Obviously, one of the challenges is, are we reporting the pure incidence or the incidence of people reporting their back pain, going to seek healthcare, etc. So obviously that is influenced by different countries, different cultures, etc. But broadly speaking, the reduction in manual labour doesn't seem to be reducing the incidence of back pain. And arguably, the increase in sitting in our community and the decreased physical activity may be contributing to an increase. So physical activity is an interesting one. People have been looking at this for a while, and sometimes with different findings, but a common finding seems to be that very low levels of physical activity may increase your risk of back pain, and very high levels of activity may also increase, and somewhere in the middle is maybe more protective.
It's from my point of view, it's interesting. I, as you can imagine, monitor lots of the media about health-related things in this job, and the two things that keep cropping up in my reading at present are sugar and sitting as being big villains in health.
Absolutely. No, sitting is definitely a popular thing at the moment with regards to the potential risks, independent of actual physical activity. But look, many patients will tell you, anecdotally, that sitting is something that causes their pain. And some colleagues of mine have just done a study where they looked at what were patients doing right before they got their back pain and compared that to a window of time, maybe a week or a month before. So using the patients as their own control and trying to look at factors that were associated with back pain. And sitting is something that does seem to come up in these studies. Again, it's that challenge that for different people it's different. So for some people sitting is the problem, and for other people it seems to be something quite different.
Mark, many of our listeners are clinicians in acute care settings. What's the message you'd like them to take away from chatting today?
Well, with regards to managing back pain, I think at the moment we need to provide simple treatments. The treatments with the best evidence in patients who've had short-term back pain are very much encouraging patients to remain active, giving patients reassurance that they've got a good prognosis. And then if patients aren't responding to those treatments, then it's appropriate, to go and get, further, not so much investigations, but further treatments. There's pretty strong evidence at the moment that imaging patients with back pain is not helpful. And that touches on an issue that I'm interested in, that I think we need to image patients in a research sense to better understand back pain, which may lead to better treatments in the future. But at the moment, there's strong evidence that imaging patients doesn't improve their outcomes. It doesn't guide treatment. So unless patients are a very small group of patients where we're considering surgery, and that really is a very, very small group, then imaging's not recommended at the moment.
That's an interesting perspective, Mark. I've been talking this morning with Professor Mark Hancock from Macquarie University Hospital. Mark's an expert in back pain and musculoskeletal physiotherapy. Mark, one of my favourite questions is about misconceptions. Are there misconceptions in your field that drive you nuts and keep you awake at night?
Well, I guess we've touched on it in some ways.
Yes.
The misconceptions that having imaging is really important, and without that, back pain can't be managed. So one of my recent PhD students actually did a survey where she asked patients, all turning up to a GP for any health condition, how important they thought it would be for them to have imaging if they had back pain. And the vast majority of them thought that it was really important to be able to get that. And at the moment, as I said, that's not the case. So we're wasting money doing that, and we're also actually not helping patients. So I guess that's something. And I guess the other frustration is, that everybody's got their own story. They had some treatment, often some quite alternative treatment that, they think is the cure to all back pain, but we know that that's not. It's just not that simple. When we test any of these interventions in big groups of people, they really don't have big effects across the broad group of people, which brings us back to that issue that we've got to find out which patients need which treatment, and that's where our focus is.
That will be intriguing research to see as it develops, Mark. That idea of anecdotal self-diagnosis, which kind of used to occur on a limited basis now with Dr. Google on hand, has been boosted astronomically. And I do in this job here stories all the time of people who have got a kind of case study of one with no rigour who very enthusiastically promote it because that's what worked for them.
Exactly, yeah.
Mark, it's been a pleasure having you on Health Academy with us this morning. I've enjoyed our chat. However, we've run out of time once again, as we often do when we talk to academics, because of all the people around, clinical academics are people who know their stuff inside and out and are happy to talk about it. So it's been a pleasure having you on. For people who have just missed our chat, the good news is we have a transcript on our website at www.hpr.fm, and you can also catch the interview both on SoundCloud and on YouTube. Professor Mark Hancock, thank you very much for your time this morning.
Thank you, Wayne. It's been a pleasure.
This is the Health Academy on Health Professional Radio.